Yeah, so my name is Anthony Schaefer. I'm a pediatric urologist here at the University of Utah. I work primarily at Primary Children's Hospital. And I come here by way of Baltimore and Boston. It's a pleasure to have many of my colleagues join me, both from the Exstrophy program that we're going to be talking about, and then some other colleagues from Utah. I apologize for the 6 minute delay. It's always in those times when your RAM decides to quit on you. So here we are. With no further ado, let me share my screen and we'll get started. Um, okay, are we seeing that okay? Okay. Let me move this toolbar down. Okay. Is that okay? Okay. Yeah, thanks for giving us, and I say us because this is not just me. Um, this is a group effort, as you're going to see, a massive group effort. But thanks for giving us the opportunity to present today. Um, and I'm going to pull the acknowledgments up front because I expect that we will have a lot to talk about. I need to acknowledge every patient and family that we've had the pleasure of working with and for, and every member of this team. I think many are on there. I see Alexa is here. That includes Dr. Matthews, Pam Artigas, Janet Gibson, Emily, Alexa, Patty. Marlo's not on there. That's an error. She definitely should be up front. Um, Solomon and Mary and David Mukisa and Dan, Janet and Paul Gibson, and you will learn to know each person's role in this. A nonprofit from Uganda called Children of Grace. Certainly, this program wouldn't be possible without Anna and Pam and Rick Artigas, and our collaborators both at Eurocare Hospital and Children's Surgical Hospital in Entebbe, for emergency and Eurocare is in Kampala. And then speaking for the clinicians, we are where we come from. And so this is not an order by any means, but what you're seeing here are, the Babe Ruth and the Pete Rose of urology and social work, because these people shaped us. Also absent, and I apologize as well, is Catherine DeVries, because she is important to this division of surgery and important to urology in the world. And so her advice and feedback has been instrumental as well. So I'll give first a brief introduction about what Exstrophy is. Then we'll talk about how it's treated. Then we'll talk about what it means to have Exstrophy in Uganda in particular. And then we'll talk about how we are addressing those gaps. So this is a picture of what bladder Exstrophy looks like. And outlined in yellow is basically the bladder and the urethra. This is a male, so you're staring inside the urinary bladder here, and then you're staring inside the urethra here. Outlined in, yeah, just a moment. Yeah, I just found this, so just give me a sec. There it is. Um, oh, oh, you know what? I'll just use my cursor. Um, So outlined in brown here are the pelvic bones. So there's a huge pubic diastasis. And then in red here is a large diastasis of the abdominal musculature. Um, and we'll have some more pictures of this in a moment. Um, Bladder exstrophy, I use that both in general and specifically, but it's part of a continuum, which is the bladder exstrophy epispadias complex, so BEEC. And going from least severe to most severe, we start with epispadias. And there's male and female epispadias. And seen on the left here is the mildest variety, in which the sort of dorsal or top surface of the male penis is open. This is not hypospadias, which is a very common birth defect. This is exceedingly rare. This would be a penile epispadias with the opening down on the top of the penis. And then here is the entree into the urinary bladder. So we're like looking in the bladder there. And this is an important distinguishment because really the treatment for what's in this right panel here and the outcomes, frankly, are drastically different than the left two panels. And then, as I already showed you, well, this is female epispadias, and so this is frequently actually missed, even in America, with this being basically the opening into the female bladder. Um, and these girls are just, they often fail to potty train and people don't recognize really what they're looking at. So this is also exceedingly rare. Then this is on the left, a male. It's the same picture we saw, just smaller. Again, this is the open bladder. These are the ureters. So basically, they're born with just a wet mucosal surface. Um, uh, this is like the prostate, which is open like a book. And then this is the epispadias, or the opening of the male urethra here. And then I already described that it's not just a soft tissue defect, but it's a bony defect, and there's a loset umbilicus. So on the right here, you see a female, and the clitoris is sort of split in two, so it's a bifid clitoris. Um, and there are other characteristics. So that's a female on the right. And then the most severe, and also fortunately the rarest variety of or uh, uh, syndrome on this spectrum is cloacal exstrophy. And this involves not just the musculoskeletal system of the pelvis, but unfortunately can also involve the hindgut as well as the neural tube. And so this is a huge problem. I show a picture here. So this is just the anterior surface of the child, but this is an omphalocele. This is actually prolapsed ileum. They have an imperforate anus. So this is a boy, and this is like a split scrotum. There's an imperforate anus, and then this is part of the hindgut. It's actually like the distal colon, and then even more lateral is the bladder plates. And so this is certainly the most severe and the trickiest to treat. So just very briefly, how do we treat that major defect? And I will say this is probably, if not the top, certainly one of the most challenging conditions to treat in pediatric urology. Um, and so these slides, this pictorial is compliments of the Mayo Clinic. So thank you. This is a baby here. The bladder is open. This is the penis with the epispadias. We make an incision line around here. And in the first operation, unless it's done emergently, it has to be combined with a pelvic osteotomy. And you basically take an open plate and make it into like a circular sphere. And there are different people sometimes extend that onto the penis, and you can do the epispadias repair up front. But it can, the approach we're going to be talking about is just closing the bladder. And then there's a staged, so operation number 2 in males would convert the epispadic male, which would be pictured here, into a male that has a closed anterior abdominal wall, pubic bones that are brought together. Again, that's in the first operation. And then their epispadias is closed. Okay. So, um, so they're just to orient people. There are no other, unless they have cloacal exstrophy and OEIS. This is isolated to the urinary tract. There's no deficits in intellectual functioning. There's no associated other syndromes. It's really just isolated to the lower urinary tract. With that said, I'm sort of simplifying this. It's a major defect. And at this point here, the patients are typically still floridly incontinent. And so these patients have a minimum of 2 if you're a female or 3 if you're a male, major operations. And so what I describe here is what's called a bladder neck reconstruction. And then this is also a continent catheterizable urinary stoma. So this is, we often use the appendix, which is brought up to the abdominal wall. Sometimes we actually plug it into the undersurface of the navel. And then they use a catheter to catheterize their appendix to get into the bladder, and then that's how they drain. Simultaneous with that, we will have done something to the bladder outlet because I told you it is wide open until a continence procedure is done. So this is kind of the standard of care in North America. There are some alternate approaches to doing this and frankly, alternate initial approaches used in Europe and other parts of the world. But for high income countries of North America, this is kind of what is typically offered to patients. So I'm going to pause there, and I'm going to switch out from PowerPoint, and we're going to hear from Martin Satuma and our patients in Uganda. So just a moment while I switch. I had all this ready, and then my RAM stopped. So
what if you are unable to realize
people hear that?
Purpose and potential because of the way you were born and where you were born? You were born with a boo-boo on your bladder. This boo-boo is called bladder exstrophy.
This condition will affect the child individually, that he will be denied, what would be like rights. He may not be able to go to school, be able to interact with others, may not be able to learn how to read and write, all because he was born with a condition. He was not part of anybody's mistake or anything like that.
Abantu whatever hasikhathi ukweletshona batshelwe letshonje injina njengoba in a way of Johnson Kwanzi.
bambere ikintu ky'obusaasi munonga hakuba kunaazire Johnson yazarwa nk'oku yabiire koona kandi obwire obwe nkaba ntiine bwenkoro bwona nkaba ntiine buyambi bwona ndikumureeba nk'oku ari naashasha naarura naakugwa ntiine n'obu naakubaasa kuguza akaanya okuba hati ekindikukora tinkikorera Johnson weena obwire obwe nkaba nkorera Johnson wenka kuba kuyaba akwata obusaasi nza omu irwariro niwe naabiire mba ntiireho amaisho abandi baba bokubonaabona enjara yaaba y'okwenda kutwita ahabw'okukorera Johnson.
Abantu bakanjuma bakinkekye bari kikora ki bakinonge kyagenda kyaraho tunonge nkigumuko ki.
Bladder exstrophy is a rare birth defect. The bladder and genitals are split in half, turned inside out, and sit outside the.
Okay. Is everyone back with me now? Okay. So that was a great introduction. You're going to learn about who produced that and so forth, because it introduces the impact of bladder exstrophy in Uganda. Okay, so everyone from my team knows every person in that video. And we know that Johnson suffered stigma, shame. Johnson was ostracized, was not in school, and really had, with the lack of access to school and or being held back, had limited ability to read and write. This then conveys issues with job prospects, limited to access to care and money for surgery. You heard about Johnson's mother and the other children in the house. And then the physician that you heard speaking there, Dr. Martin Satuma, was a pediatric surgeon who did not know how to take care of bladder exstrophy. So we're going to walk through how we improve the situation. But before we do that, let me just focus people in on Africa. So this is Africa. Uganda is in East Africa, sub-Saharan East Africa. It's bordered by Kenya to the east, and Tanzania and Rwanda are very close by. It is a country of 40 million citizens, half of which are under 18. In this country, there are 5 pediatric surgeons, 1 pediatric urologist, no pediatric orthopedists, and 3 pediatric anesthesiologists. There's 1 tertiary care hospital in the capital, actually in Kampala, the biggest city. And that is, as we have come to learn, it's a little bit of a fee-for-service hospital. It's a public hospital, but you have to pay for your care that you receive there. So, and I'm gonna explain in much more detail how the Association for the Bladder Exstrophy community got involved. But I'll call it ABEC, of which all of the core team members, which I'll introduce in a moment, are board members of. ABEC is the largest nonprofit specifically focused on bladder exstrophy, not only in North America, but in the world. So, so this is one of our mission statements, and that is to reach all people affected by bladder exstrophy. Part of the international outreach of ABEC is to provide access to care, training of physicians in places where this care is not currently present, and to provide annual follow-up and create a community, and also provide some support for our programs, which you're going to hear about. This is our core team. Please note that I'm using we and our because this is a group effort. This is led by Pam Artigas. I, together with Dr. Ron Matthews, am the pediatric urologists that are the lead surgeons. Marlo Eldridge is a pediatric nurse practitioner who has over 25 years of experience treating bladder exstrophy specifically. I should say Dr. Matthews and I trained at Johns Hopkins, which is the preeminent institution for bladder exstrophy care in the world. So that's kind of why we're here. Janet is also a board member of ABEC, and you will come to understand within the next 5 minutes how she got involved. I see that Emily is on this call. Emily is an amazing clinical social worker who has dedicated the vast majority of her career to improving the lives of people with bladder exstrophy. And then sort of at 5 o'clock here is David Mukisa. You're going to learn also in the next 5 minutes how David got involved. But before I introduce those people, let me tell you what our approach is. So we're a team of experts from North America. And I should say that we can probably count on 2 hands, perhaps 24 actually, people that would be considered sort of world-class experts in exstrophy care. And all of those people are on our team. Then there are others from London, for example, and Seattle and so forth. But yeah, so a little bit using the approach that all of us learned, or at least I should say myself, Dr. Matthews and Marlo, learned from Dr. Gearhart, who was on the acknowledgements, and his predecessor, Robert Jeffs at Johns Hopkins. We learned this multidisciplinary approach to exstrophy care. Okay, so this includes pediatric urology and orthopedics. It's not possible to bring state-of-the-art care outside of the operating room and outside of North America without an orthopedist, which is important and will be important for our discussion. Marlo Eldridge, the doctor of nurse practitioner, is extremely vital to both preoperative and postoperative preparation and training and how to take care of it. Before she assumed her NP role at Hopkins, she was a floor nurse on the exstrophy ward at Johns Hopkins, as is all the other members of our team. So these are people that know a lot about how to take care of both the pre and postoperative care. And then we have anesthesia. So these are children that are typically in the hospital after their first closure for 3 to 4 weeks. They have 4 fractures in their bony pelvis. They have 4 catheters in their urinary tract. So they have a lot of discomfort, and it wouldn't be without our pediatric anesthesia colleagues that we could do this work. And then equally important is my colleague Emily. because she is extremely gifted at knowing what bladder exstrophy is, how it impacts the patients, and what strategies can be done to educate them and help them cope with their situation. And then also, specifically as it applies to Uganda, we have really, as I said before, boots on the ground people that help us with our mission. These are our goals here. So we wanted to teach really a multidisciplinary state-of-the-art approach of bladder exstrophy care to Ugandan healthcare providers. I think I already outlaid why this is important. It's a country of 20 million children under 18. There are too few and really less than a half dozen providers and only one trained pediatric urologist that would have experience in exstrophy. Our goal is to work towards graduated surgical and nursing responsibilities. We also sort of ask for actually a stable yearly presence of the same Ugandan pediatric surgeons and urologists and nursing team so that we can create a sustainable self-supporting model. And so we can leave Uganda in the next decade. So this journey began in 2010 with the birth of Solomon. Solomon was born with cloacal exstrophy, and he's the parent of David Mukisa. David is on the board of ABEC. David currently lives in Kampala, Uganda. He's a pharmacist. And he and Mary gave birth to beautiful Solomon. And when they went to the public hospital, there was no one there to take care of David. So Janet and Paul, her husband, who were in Uganda working for the nonprofit Children of Grace, drove David and his parents to Kenya to receive care. Excuse me. And with that, Janet really let her fingers do the walking. And she connected with Pam Artigas, who is the executive director of ABEC. And together they have formed a great partnership. So it should be obvious that Janet is our sort of North American connection to Uganda via Solomon and David and Mary. And Pam is the advocate for the bladder exstrophy community. And so together, Janet and Pam in 2015 started this partnership. The problem, though, as we outlined, was that there was no one in Uganda to take care of these people. So starting in 2016, Pam raised money and paid for 3 patients and a social worker to stay with them for a whole month, and a pediatric surgeon to go to India to start learning about bladder exstrophy care. That's another mission that Pam has, is to be the exstrophy community's face for a mission that is on the Indian subcontinent. And we can talk about that more if you'd like. Also, Janet, with her connections from her and Paul's nonprofit and simply living there for 3 years, started interviewing surgeons in Uganda who might be interested in taking this on. And so it was Dr. Satuma who identified himself. That was the surgeon that was speaking on the video that you saw. And he took the lead for bladder exstrophy care in Uganda. And he was the surgeon that went to India, not once, but 3 times. So then in 2017, this continued. And at that point, the planning for how can we bring expert care to Uganda began. I'm sorry, that's a duplicate there, the 3 surgeons. So the partnership, so Pam was in the process of identifying leaders and experts from North America that could go to Uganda and teach them. We needed a place to go. And so we identified a hospital in Kampala called Eurocare. This is a hospital that takes care of urology only patients and nephrology patients. The leader of that was acknowledged earlier. That is Stephen Watia and his wife Stella own and operate that facility. And so we had our team. We had Dr. Matthews, who was the surgeon lead. Dr. Matthews then recruited myself and Marlo, and Emily is well known in the exstrophy space. Together, we recruited our colleagues from nursing and so forth. And so we, I should say, Dr. Matthews went for the first time to plan and to see the facility at Eurocare and try to get our ducks in a row. So our first mission happened in 2019. This was intentionally a small mission where we closed 1 patient and took care of 1 boy with epispadias, but we met lots and lots of people who had been underserved or simply not served. So these 12 cystos, planning and consultations. So while I'm in the operating room for 12 hours, Emily and Marlo are talking to the patients, teaching them how to catheterize, explaining to them what bladder exstrophy is, and working with them. So myself and Dr. Matthews were the surgeons. Marlo was the only nurse, and Emily, and then Pamela Artigas and Janet Gibson came with us. Our learner was Dr. Satuma, and he was with us with every patient and learned about it. And then Eurocare has a urology residency, and so they were, all of their residents were involved as well. Very importantly, Emily and Pam and Janet put on an outstanding education day because it's not just an education day, but it's really community building and to create a bladder exstrophy community in Uganda. And that was the first such thing probably in East Africa. So we all know what happened in 2020. We all are committed to doing this once a year at least. And then COVID-19 happened in 2020 and 2021. Unfortunately, in the summer of 2022, there was an Ebola outbreak in Uganda. And so our plans to go in October 2022 had to be ceased as well. There were 2 missions in 2023. The first was in February, the second in October, and I'm going to go over those. So we continued our outreach to patients, and this included some additional closures. It's important to recognize that these are very intense post-operative patients that have a lot of pain needs and a lot of management and really need ICU level care for several days afterwards to manage their tubes and drains and wounds and so forth and their pain. We also, on that second mission, took care of a patient who was completely ostracized and lived in his parents' kitchen. Balam didn't go to school. His siblings couldn't understand why he didn't go to school because his parents didn't share with them what their brother had. And so we met and sought a cure for Balam, which we can talk about if people have questions. And then we continued our epispadias repairs and other consultations. At this point, we had to increase our complement of volunteers. As I said, it's very intense, not only in the operating room, but a lot of exstrophy surgeons say the care of the exstrophy patient begins the moment you leave the operating room. So without my colleagues, this mission would not be possible. Importantly, working with Eurocare and Dr. Wachia and the leadership there, there was an awesome showing of really folks from Kenya, Tanzania, and other places to also participate in our didactics and academics. And so each of us gave at least one talk. This includes nursing education, social work education. We also bring a patient advocate from North America, someone that either has exstrophy or a family member of someone that has exstrophy. So our patients and family in Uganda can understand that you can thrive and live a productive life with this condition. And then Emily continued with her education day. And just like I said last time, this is not, fun and games. It's basically her working and doing psychosocial assessments to assess the patient's readiness and so forth for the next steps of their care. And really, if you also talk to an exstrophy surgeon, you will know that we lean heavy on Emily and Marla's expertise to give us really the green light and the go-ahead for what is planned. But we reached several obstacles. So unfortunately, Dr. Satuma left this earth early. He had amyloidosis and died of renal failure. There is no dialysis in Uganda. And with that, our efforts to train our in-country advocate was gone. We also struggled substantially with the lack of a pediatric specific facility. Bless their souls, the nursing team, they really stepped it up and helped take care of our patients and did their best to teach. But we quickly realized by the end of that week that perhaps a separate clinical facility would be a better place for us. On top of that, the original agreement between ABEC and Eurocare, especially with the amount of patients that we were coming to find, was difficult to sustain financially. So these were obstacles, and it was really at that second mission that we tried to identify other facilities that may be a better fit for us. And enter our blessing in disguise, the Children's Surgical Hospital in Entebbe. I'll speak briefly about that. This is the first elective surgery pediatric hospital from emergency. Does anyone on the call know Emergency? It's an Italian nonprofit. Okay, so it's based in Milan, and they have, I think, 6 hospitals in Africa, excuse me, in Afghanistan. And basically they go to war-torn countries. So Sierra Leone, Afghanistan, Sudan, and other places to provide really trauma care is wrong, but they take care of both, citizens and I guess soldiers of war-torn countries. And so they also have actually a cardiac specific hospital in Sudan, where they do cardiac surgery. It's become a regional, if not continent, referral center for some major cardiac surgery, notwithstanding South Africa. But they draw from really all over Africa for cardiac surgery. And so we've come to learn that the Minister of Health of Uganda was at a function at that hospital and offered this land that you see here for Emergency to start their first elective pediatric specific hospital. And so this was a partnership with the Ugandan Minister of Health and Emergency. And they call it the Children's Surgical Hospital, CSH, in Entebbe. So that's important. It's the Minister of Health, and that's going to come up as another major barrier in a moment, because there wasn't a lot of crosstalk within the government and the healthcare leadership in Uganda. But nevertheless, we can talk about that in more detail. This is a beautiful facility. It feels like you're walking into Milan. However, it is a teaching facility. So they not only employ lots of people from the capital of Entebbe, but their nursing, leadership, and surgical staff are all partly Ugandan, and then they're taught by Italians and others. There is always a pediatric surgeon from Europe, Italy or Europe, that is there to teach the pediatric surgeon or 2 or 3 that are on staff at CSH. So we pitched this to them. This is our model that we came up with. And that was that we would start 2-week exstrophy specific missions. And we identified our needs in that, we needed a facility, we needed assistance with supply chain and procurement of suture and so forth. And we needed a pediatric facility. And CSH Entebbe is a free hospital. So, but we, anyways, yeah. So we suggested this as a potential outline for us to sort of maximize our teaching, maximize our care, and also provide a sustainable model. So really, this would be 2 weeks for 6 to 8 years so that we could train the local staff. And so that we can leave and they can be on solid footing. So, in the beginning we would do, and they would observe, and then that will shift as the local community gains experience with that. So our third mission was in 2023. I guess actually less than 6 months ago. And it was very successful. We purposely, for this one, kept it still kind of small. And we only went for 5 surgery days and 7 days with clinic and so forth. We did not have the education component because we were going to just identify what's possible and so forth. And at the end of that trip, I'm happy to announce that we signed an MOU, which between ABEC and Emergency for a several-year partnership. And you know, we got I shouldn't say got, we were offered a lot of the things that we felt were important and necessary. So if these are the barriers, we have overcome a lot of these. So patient access is different. This is a free hospital. It's a pediatric specific hospital. We are working with a pediatric orthopedist. We also brought really the preeminent leader in pediatric orthopedics as it pertains to bladder exstrophy and taught Moses. We have identified pediatric surgeons. The reason why this is a thumbs down currently is that there is some in-country medical and governmental politics. And so that's where the Ministry of Health and the lack of communication with the leadership at the what's called Level 7 hospital in Uganda, Malago, they were not involved. And so there was a substantial conflict of interest. And unfortunately, the emergency leadership is still digging themselves out of that hole that they didn't really create. So I'm certain that's not everything, but this is what we have come to learn. Other things that we have identified is what is our sustainability like? What is our sustainability plan for all members of that team? Because we are not just two surgeons. We are not just a social worker. We're not just a nurse. We are a cohesive group of Exstrophy experts. And so it's hard to find people that meet those needs. And then state-of-the-art care in the United States is not the same as state-of-the-art care in Uganda. So what I'm referring to here specifically is one of the goals of Exstrophy care is urinary continence. And some of the options that we offer patients in Salt Lake City or Baltimore or California are not necessarily applicable to someone that has to get on a motorbike and travel 8 hours over 20 miles to get to the nearest hospital. And so I can talk about that in a moment, but we have worked with our emergency colleagues and our social workers and psychology team there to put together what we feel is a good strategy for urinary continence for our patients there. And then supply chain constraints is a potential hurdle that is still a work in progress, but there is a lot of experience and a nice transition plan in place at emergency. So these are our successes here. Okay, so we've taken care of 35 patients with exstrophy. The demographics are listed there on the left, or epispadias. Notably absent is cloacal exstrophy. So we've already bitten off a big chunk, and that involves incorporating neurosurgery and so on and so forth. So we are just focusing on epispadias, female and male, and bladder exstrophy. And what's on in table 2 here is you see we've done 6 closures. Unfortunately, one of these failed. And there are multiple reasons for that. We have done 1 patient and we changed Balam's life. Balam followed us to our hotel because we kept missing him at every stop because we needed to see him 6 months after his cystectomy and ileoconduit, and he found us, and he is a changed man. He's going to become a mechanic, has a completely different affect, and so as much as we struggled with a lot of things, that success is outstanding. I credit Marlo and Emily with teaching one patient how to become continent, because all she needed to do was catheterize her augmented bladder. And then we have multiple procedures planned for people, including lots of closures and so forth. So, you know, this is us overcoming these hurdles with patient access, our sustainability, and then trying to modify our approach for what does state of the art mean in Uganda. And I can talk in more, I alluded to some of these issues with the sort of in-country politics and then the MD training, but we'll take our victories. So with that, I would like to again acknowledge my colleagues. While I might be the face today, this is a team effort. And you see, I don't see everyone on here, but I see Emily and Alexa. I don't know if my other colleagues are here, but thank you everyone for listening, and myself and all of my partners who are on the call, open it up to questions. So please.
Thank you so much. That was a fantastic talk, and you've got an amazing team of committed professionals.